Hey, so this is the end of our first unit of real content, the human voice. These portions, the clinical connections, they're a little bit more to do with the real world, what I do. And what I do is I see patients and teach students how to see voice patients, basically. And so some of these videos and other resources, a lot of them are again walking you through case studies rather than have you do case studies. Some of them are more demonstrative or teaching and to help you learn how to do certain things, but always about how to apply or why do you need to know what you're going to learn. So for this unit, this week's content, I really thought it would be really neat to talk about this case study. Now I'm going to tell you again, unfortunately, my delusion of grandeur of, oh, I'm going to actually have the audio sample and all that, it hasn't worked out for me. If and when I do these again, I'll probably try to incorporate some of that. But again, I want to be sure and let you see and walk you through more of these case studies. So let's kind of jump into this case study in particular is of a musical theater performer with a laryngeal pathology. And what's really interesting is if I want you to walk away with anything from this case, it really boils down to three things. And why this case at this point in the semester? Well, first of all, it emphasizes the importance of patient perspective and voice science. You've got to know your anatomy and physiology. You've got to know certain norms, et cetera. It also considers perceptual evaluation with and without laryngeal imaging because this patient did not sound like he had anything wrong. He did not have dysphonia or hoarseness, right? And then it also highlights some clinical realities with voice therapy clients or patients that a lot of us experience. And so if you get anything out of this kind of walkthrough video, I'm hoping that it will help you at least achieve these three things of, why is it important to listen to my patient as well as know my black and white, very objective facts? Why is it important that I rely and know that my best tools are my ears, my eyes, and my gut, but also I need some sort of other tool to help validate those things because every once in a while we're humans and we're wrong. And then clinical practice is full of lots of lessons that we can't teach you in school. And some of those you start realizing and accepting the more that you do it. So let's talk a little bit about who this patient was. So we're going to call him FM. He was a 24-year-old male theater arts performer. He had a bachelor's degree in music, specifically vocal performance, had been trained, several voice lessons. He was from out of state, and he was actually referred to us at the WT Speech and Hearing Clinic from an outside university voice center. In fact, one of a pretty legitimate university voice center. Some of the clinicians there have written textbooks and whatnot. The gentleman was coming in for a seasonal gig. He was pretty much fresh out of school, but he'd been working professionally for about 2 years. And so he was supporting himself by performing. So he was doing a pretty good job, mostly in summer stock theater, occasional regional operas. He described himself as a baritoner, which is really kind of an informal musical term, but really baritone, but could sing tenor, which is not uncommon, really. And the most profound part about his case is that we were fortunate enough that the referral included from the outside university voice center included the speech language pathologist and otolaryngologist report. And so they had already scoped him and did a stroboscopy. And there was a confirmed true vocal fold ectasia. And so this picture that's to the right, this is not the patient. This is an example of what an ectasia is. And so you'll also hear you will hear ectasia and varices used kind of synonymously. And essentially what ectasias and varices are they happen due to phonotrauma. So use of the voice, high vocal demands. I don't want to say vocal abuse or poor vocal technique, because that's not always the case, but basically it's dilated or abnormal blood vessels um, that are basically underneath the surface of the true vocal folds. So right underneath the epithelium and superficial layer. They're not a full on hemorrhage yet, but they can rupture and bleed. And then with that bleeding, if they do have a full-fledged vocal fold hemorrhage, that vocal fold is going to be stiff. So they'd already found that, which is why they said, he's about to take this gig in your area, and we really want him to see a voice therapist. And so we got him in. He was referred. We got everything approved. Other than he had a surgery when he was a teenager on his back, but he didn't really have any remarkable past medical history at all. He was a fairly healthy individual. He did a lot of cardio aerobic exercise. He considered himself more a singer and actor than he was a dancer, but he had taken dance lessons, of course. So he was in pretty good physical condition. Probably, again, having been one myself as a theater arts or fine arts person, I mean, he said that he enjoyed having a good time here and there in terms of alcohol consumption, but really he was quite healthy. We really didn't know that there was anything else that it impacted his ability to perform, and especially when it came to his voice. He took some over-the-counter like NSAIDs, so that would be Tylenol, aspirin, etc., for pain, maybe the over-the-counter allergy medication, but really, again, fairly healthy individual. So chief complaints, you'll see this as CC in clinical documentation. His main one was this tension or this tightness when he was singing. That's most of these are direct quotes from him, actually. He just reported that when he sang, not so much when he spoke, but when he sang, he felt this tension. He reported a decreased range. Again, he's a baritone, which is kind of for male voices, the middle, not too high, not too low, but could sing tenor. And he was reporting decreased range. He reported some reduced vocal support. Later on, when we did his actual evaluation and collected some numbers and figures and data, he actually had a decent amount of vocal effort. And surprisingly, he denied vocal fatigue, and he denied what we call odinophonia, or painful speaking and voicing. What was interesting is he even said that he was worried, because I could tell from the report that we received, he was educated that, we understand you've got to work, but if this ectasia becomes a full-on hemorrhage, there's possible damage. And so one of the things that you learn the more that you do voice therapy and work with even vocational vocal athletes or professional voice users, those are people like singers, actors, teachers, but they do it not just professionally, but they also do it recreationally. They can be very sensitive about their voices. And so this is a picture of outdoor summer stock theater in our own backyard in the Palo Duro Canyon. Vocal performers have to have their voice to be able to earn their living, including those in Texas. It is a professional paid gig. And so the building may not have the best acoustics. There may be a very regimented, there's all sorts of barriers and pressures, just like any other job that performers have to consider. And when their voice is part of that, it really can be nervous. And in my experience, rightfully so, vocal performers can actually be very sensitive about their voice. So our voice evaluation, I'm going to kind of summarize this very quickly and briefly for you. When he came to our clinic, we tailored kind of your ideal comprehensive voice evaluation. You'll notice that there's not any laryngeal function studies, which means acoustic or aerodynamic assessment, because most of those are validated and normed for the speaking voice, not for the singing voice. So we use the Singing Voice Handicap Index 10 item, or the SVHI 10. His score was a 26 out of 40. So that's about a moderate impact on quality of life, or a moderate handicap for the singing voice. There's another patient-reported outcome measure known as the Vocal Tract Discomfort Scale, and there's several vocal symptoms that you rate both severity as well as frequency. And across the board, he had his symptoms per his report, or per the VTDS, didn't happen very often, but when they did happen, they were quite severe, which is really, really interesting. Auditory perceptual, I mean, overall, he sounded fine in speech. He didn't sound terrible in singing, except for there were just, to a trained ear, you could tell when he was straining, when he was pushing a little bit. And then when we scoped him, I like to do the flexible endoscopy for my singers. And really, what was interesting is as soon as he said it, he's like, oh my gosh, it's gotten bigger. Well, he'd already moved here for the brief time that he was going to be in the show, and he had been doing rehearsals. The show had not opened yet. And he said, it's getting worse. And he showed me a picture, and indeed, it was getting worse. So, again, could we have even argued that he had a very mild vocal hemorrhage at this point? Probably. Again, that's outside of my scope of practice. But I made note of that in my report of per his report, and looking at it, it was getting worse. So, what did we do for FM? So his diagnosis were dysphonia, R49.0, basically very mild, but again, more in the singing voice. And of course, disease of the vocal folds, J83.3. Those are the codes we use in insurance. Now you'll notice there's an asterisk by that one. That was already established by the ENT previously who saw him at the voice center he was referred from. Speech language pathologists should be cautious in using that code. It doesn't mean that you can't use that code. But again, it's always best if it's already came from the ENT because it's set up. So my recommendations for this patient were that I wanted him to see one of our local ENTs, specifically one of the two laryngologists or ENTs that specialize in the larynx and voice. There's two in town, really, in my opinion. And so really wanted to do that. Contacted the office, explained the situation, and we got him in within a week. Voice therapy 1 time per week during the day. And then, of course, collaboration with the directors of the show. And again, this is a patient decision. If he wanted me to, I would have provided, a note that says he was under my care and et cetera. But again, because of HIPAA and everything, I really can't just share anything and everything about this patient's history and whatnot. So his therapy goals were to meet vocal demands and continue vocal performance. It's not very realistic for us to recommend complete vocal rest because, again, he was on contract. He was getting paid to rehearse and then perform in the show. So our ultimate thing was he's got a job to do. Let's help him meet that job by continuing vocal performance using kind of some of the other strategies and goals. So minimize, prevent further vocal injury. We were going to do that through routine laryngeal video stroboscopy. In this case, it's more therapeutic than evaluative based to make sure that that's not getting any worse. Trial and implement indirect techniques and strategies for vocal wellness and hygiene. He hydrated pretty well. But I mean, I think there were some vocal wellness, vocal hygiene, vocal health issues that he could do better, maybe conserve during rehearsals so he could rest up for the show. Of course, we want him to be able to sing. That's what his job was. So using some of those more direct voice therapy strategies, which you'll learn more about later. And then, of course, report increased confidence, reduce shame. Singers and actors especially feel like they're damaged goods when something's wrong with their voice. And then improved vocal sensations. I'm a big fan of education and counseling as part of what we do. And again, at the end of the day, if the patient can do these things, then I'm happy. But let's talk a little bit of what actually happened as we conclude this case. So he's in the middle of rehearsals. He comes to his first 2 or 3 therapy sessions, and they go great. We do some diagnostic probing, decide like these are going to work out well. Here's an exercise regimen, help you coach through it. But after that, I think 3rd session, he starts canceling. And he wasn't scheduled like at 8 o'clock in the morning. He was scheduled right before lunch. He starts canceling, then he starts no-showing. And unfortunately, it was just time to completely and totally discharge him, which is sad. Was it a deal about money? I'm not sure. Was it a deal about rehearsals? I'm not sure. Did he think he was doing okay? I'm not sure. Again, when they cancel and no-show, there's only so much we can do, even though we tried to call and follow up with him. And so some things that I learned from this case and doing this case is that, again, we cannot hear a voice disorder. This is why we have the golden rule of voice therapy, which is that a patient should be examined by a physical doctor, especially preferably an ENT, to do laryngeal imaging, because just because they're not dysphonic doesn't mean that there's not pathology that could cause problems, right? So again, I want you to kind of know that dysphonia and a voice disorder are not synonymous. They're very similar, but they're not the same. You can have a voice disorder and not be quote unquote hoarse. Performers, and again, I've done this long enough and I've done voice long enough to know that performers really do care about their voice, but they may have barriers. Could he afford voice therapy even with insurance? Who knows? He was still on his mom and dad's insurance. Maybe they told him, like, you don't really need to be doing this. Do what you've been told by the other voice therapist and fly straight. Maybe he was just exhausted because the show was in the summer and they were getting closer to opening. Maybe he was just exhausted. Who knows? So there's also barriers that our patients can't control, and then there's choices that they make. But again, I like to think that really performers care about their voice, but they still have barriers. It's no different than we all care about our health, but we make unhealthy choices. I was very appreciative of the local ENT who got him in and examined him and said, yeah, I agree with Zeth's interpretation and everything. And for this type of problem, you need to do voice therapy. And I was very impressed and thankful to get the referral. And that had all the information and made everything much easier. I was able to do some things very quickly because I had pretty much a case history. I just wanted to clarify how things were at status quo. So again, when I say interprofessional, I don't mean just outside my discipline. I also mean within the discipline. So that would be more intra-professional practice. But very interesting case, very common case, some things reinforced, some new things learned. And I hope that you have learned something from this little walkthrough of this case. Thank you, and we will see you later.